One of the studies that recently came to light, as in recently was published, is something called the BEST CLI trial, which you're going to hear a lot about. This is a trial that really was 10 years in the making, but it has a lot of wonderful things to it, but also a lot of flaws. And so it is really important to sort of understand where it came from, how it emerged, and what new data is going to be coming from it to really be able to apply it to practice today. So to begin with, I'll give you just some basic overlying things about the BEST CLI trial. Number one, the question that it was trying to answer was, should we be doing endovascular procedures or open procedures, as in bypasses, for patients with critical limb ischemia? I will start out by saying the question in and of itself is a bit stupid to start out with, because 10 years ago, that was the question. Do we do endo? Do we do open? Now, anybody who's in this space knows you do both, and you use what you need to use for a particular patient. So the real question is, what patient fits endo versus what patient fits open, and understanding the nuances that get a patient to that point. That all being said, the study still stands that the ultimate result of the study was, if you are a patient that can undergo an open bypass surgery, as in you're medically fit to undergo it, and you have a nice juicy piece of saphenous vein. So that's the vein in your leg that you can see actually when you look on the inner side of your leg. If you have a piece of that vein that's long enough to be able to do a bypass, then you are best served by getting a bypass first. Now, that is a phenomenon that we are all trained to understand. And I don't think that was ever really in question in and of itself. But the study did support what we already know, which is that if you have that, you can undergo it, you're young, and you have a good target, that indeed that's the right thing to do. But what has now happened is, obviously, when you're doing limb salvage, there are a number of different players in the field. And when you go to see a doctor who's a vascular specialist, as you can see from this panel already, you're going to have a slew of different types of doctors. You will have people who are trained as vascular surgeons. You will have people sometimes who are general surgeons. You will have people who are interventional radiologists, and you will have people that are interventional cardiologists, all of which are extremely specialized and educated in limb salvage. So being an IR doctor, an IC doctor, a vascular surgeon does not mean that you are a limb salvage specialist in and of itself. You as the patient are going to have to do good digging to figure out indeed if that person is somebody that you should be sitting in front of. And then, of course, all of these people who certainly who are on our panel, and myself included, are well familiar with the BEST CLI trial and would put this new data into our practices. Most of us really not changing what we already kind of do. So with that, I'm going to once again just bring up our panel here just to show you the wonderful diversity. To start out with, all wonderful friends of mine, Dr. Mustapha, who's an interventional cardiologist known as the Leg Saver, who is the president and CEO of endovascular intervention at the ACV centers. We have Dr. Petrone, who you can all see there, this beautiful family, who's an IR doctor, who's London-based and an expert in endovascular procedures. We have Dr. Zah, who is from Spain, who trained at Montefiores and then went over and now is a consultant at the Hospital de Cruces in Spain. And he's a vascular surgeon. And we have Dr. Rundback, who is an interventional radiologist and a advanced endovascular colleague of mine who runs the vascular specialists in New Jersey and the New Jersey Endo and Amputation Prevention Group. And finally, we have, last but not least, Mr. Rouse, who runs the EndoCore Lab. And why was he on this panel? Because he has designed multiple studies that deal with peripheral artery disease treatment. So he can talk to us about how good or bad this BEST CLI study is and what there's no study that's really excellent. So it's important to know what the pitfalls and perils are of all studies. So with that, I'm going to open it up, asking Dr. Mustapha if you're available, and then I will go down the list of people to answer. Can we start out by just asking a very simple question? How do you define the best endo versus the best surgical approach to limb salvage?
Good morning, and thank you, everyone. Anita, as always, pleasure. I always love your midline approach to things, which is meaning doing the best thing for the patients, right? Actually, you answered my questions really. A patient that meets the criteria for bypass and based on the best CLI selection criteria. So if they have a good, nice vein, good comorbidities, and good surgical techniques, they do well. Endovascular patients that don't meet those criteria, we have options to treat them endovascularly. And those are the patients that we actually all deal with on a daily basis. And they don't have a good conduit distally. They don't have a good vein. And they have many comorbidities. And these are the majority of the patients. So these are the ones that actually benefit best from endovascular revascularization. And they tend to do not as well as, the patient with less comorbidities, good vein, good target, right? But they're sicker, much sicker. And if you leave them alone, as you know, their average lifespan is 2.7 years. And if you treat them, you can actually prolong their life. We have patients now, they've been with us for 12 years. So you can prolong their life as long as you can. Once they get an amputation, the lifespan deteriorates quickly and they die faster. So the best endovascular therapy for patients are patients that have complex disease with no good targets, vessel distally, and no good saphenous vein and many comorbidities.
Right. And Dr. Bertrand, can I ask you the same question? When you're talking to a patient and you're trying to ask them, what they want and how they fit into whether or not they would be a patient that would be best for endo versus best for open, how do you approach this type of patient in the short time that we have to discuss with them to decide whether or not you're going to send this to, in your case, it would be, a vascular surgeon to look for bypass options? Are you the one who's doing the ultrasound to check out the vein? Or are you saying, let's do endo first? How do you approach a patient?
Oh, thank you. That's a great question, actually, because it's the core of all the questions. The thing is, like in the UK, we work in a multidisciplinary team. So we don't have to send patients right and left to other specialists. We work as a team. And actually, when I see my patients, I always ask, of course, I talk about, what the options are. Of course, what do they expect and how fit they are for any kind of surgery, of course. Then I always ask for, especially I think this is what the best CLI trial will add probably to our practice. It's good practice to ask for the duplex scan of the great saphenous vein in order to get an answer like, is the patient a potential candidate for a bypass? We know by literature that 30% of the patients are not able to get a great saphenous vein bypass because they don't have a great saphenous vein available. So essentially, it's important when you discuss things with a patient to know at least if they meet the criteria to go for a bypass. So if the patient, of course, doesn't fit for a bypass, we've seen in this best CLI trial that the prosthetic bypass, the ones that is done with a sort of a tube, a prosthetic tube, then has the same results of the endo. So I think that in my experience, these patients benefit from endo because it's less invasive and, they usually patients prefer this option, especially if it's well done, let's say.
Thank you. That's actually a great point he brought up as he was mentioning about the multidisciplinary team. There was a comment that was made earlier, this question about above or below and whether or not vein or plastic is better. I will tell you from the vascular surgery side, if you're doing a femoral, so that's from your groin, to above knee bypass, so that's above your knee quite literally, the patency rate, so how long the graft that we put in stays open and doesn't clot, is the same whether you use plastic or you use vein. And when you go below the knee, then the vein has better patency, which is, again, that's a very established, been around for a long time. That's not something that's much of a debate these days. But nowadays, with the advancement of endovascular therapy and skill, especially with the different people that we have even online, it's really key to note that some of the old rules about, hey, if the segment of your artery that's blocked is this long, you should always have an open surgery, are out the window. We don't treat patients like that these days. Now, if you can get through the lesion and you can give a decent patency, even of, let's say, a year or 2 years, and then the patient doesn't lose the option of a bypass 2 years from now, why wouldn't you start the clock on that bypass 2 years from now instead of today? So there's a lot of debate and discussion, and having that multidisciplinary team where there's a comfort level between the interventionalist or the vascular surgeon or the vascular surgeon and their podiatrist and the wound care center is fundamental to your ultimate outcome as the patient, because none of us who are vascular interventionalists or vascular surgeons, by just getting open your blood vessel, have done the deed. The most important thing is what comes after that to maintain that patency and get you to heal that wound so that that leg can be saved, because that's the main point. Who cares what our final bypass looks like? So I want to go on to ask another question to the whole group here. Dr. Runback, if you are on, I'd love to ask you, can you talk to me about how you talk to patients when a patient walks into your office with that black toe? This is so much information for 15 minutes to get through. How do you have a conversation with the patient to give them the best option when you have someone come to the office?
Thanks, Anahitadua. I mean, first of all, everything you said is spectacular. I really appreciate your perspective. And I think for the patients on this, it's just a wonderful opportunity to better engage and better understand, as you're suggesting, these complex decision-making. So, you know, patients come in, this is what we do. We have a complex critical limb ischemia practice. It's pretty much 80% of what I do. And obviously, navigating or negotiating the options with patients is difficult. They don't necessarily understand the vocabulary like we do. But fundamentally, we go through the appropriate testing, generally, obviously, arterial imaging or sometimes cross-sectional imaging, to determine our suspicion that there is indeed blockage in the underlying arteries contributing to this problem. So the first conversation is that we think that this is the problem and we need to get appropriate testing to confirm it. However, we do have an initial conversation and then a subsequent conversation once we find this, that, you know, really watchful waiting is not necessarily the best idea. If there's, you know, certainly blockages in the arteries associated with the gangrene or the ulceration, I think the best suggestion is that some form of restoring blood flow or revascularization is warranted. And the question is, what is the best form? Now, in our practice, actually, we take an endovascular first approach. So we don't really jump and do that saphenous vein mapping. And part of that is in looking at the best CLI results, it seems to suggest that if you had technically successful endovascular procedures, then the curves, that is the success rate beyond that initial 30 days, were more or less the same, even if you had a good intact saphenous vein. And interestingly, if you look at the quality of life or the patient, preference, almost everyone would prefer a minimally invasive outpatient procedure. So we really kind of talk to them about that option first, but do say that in the event that this is not successful, or if we're successful and the disease comes back again, 1 or 2 times, we would look into a surgical option. And generally, patients sort of find that to be a very, very favorable approach. They like this idea that we've sort of explored at least the initial and potential long-term options and given them an immediate path to revascularization. I mean, from a very practical point of view, scheduling an endovascular procedure for these patients who are often in need is often much more streamlined than scheduling an open surgical procedure. So that's a consideration as well. So that's how we approach it. And, as you know, we all hope there'd be better technical success with the endovascular approach in the best CLI trial. And that's just sort of probably, kind of normal variations. But, in our practice, we can cross those blockages and restore blood flow closer to 90% of the time, which is, substantially better than seen in that trial. And I think that'll make a difference.
I think that's an excellent point you just brought up about the variability in the providers. That was a major point of the best CLI trial. And I'll be asking Dr. Yasa and Mr. Val's a question in a moment. But this idea of like the same. So when you're designing a trial, and Mr. Val's can speak to this, you must have kind of similar groups on both sides and similar action to the patient on both sides. So what do I mean by that? If I tell you that I am doing a fem to distal bypass with vein in Mass General today, and somebody in Timbuktu is doing the same procedure, aside from a tiny little bit of here and there variation, the steps of the procedure are the same. First you do this, first you do that, then you do this to the vein, it's very similar. But if I tell you that I am recannulizing or opening up a tibial vessel in my patient, and Dr. Runback is doing the same thing in Jersey today, we could have totally different. I could use a balloon. He could be using arthrectomy. I could be coming from the foot. He could be coming up and over. So there is extreme heterogeneity in how you achieve the goal. So in best CLI, there was no control over the endovascular interventional arm, in that we didn't say that these are the steps you must follow. And so people were different in what they did. The other thing that was very different between the groups is, what do you do after? Because on average, the data says it takes 200 days from when you open blood flow to heal a wound. If it takes 200 days, that means at least 200 days post your procedure, that blood vessel that we opened up needs to stay open. And how do you do that? You put people on blood thinners. And there's all kinds of controversy about blood thinners and who should be on what. Dr. Runback may be putting a patient on Plavix. I may start Eliquis, which is a much more hardcore drug. We could be starting, stopping. And so it's hard to control for all of that. This is still the best study we have out there, but it's got a lot of flaws. And so with that, I want to ask Dr. Yasa about the surgical side of things, as he's a vascular surgeon. Dr. Yasa, how do you decide whether you're doing endo versus open, given that you know obviously can go both ways? And what I really want to ask you is about when you do your angiogram, because all patients essentially in these days get an angiogram before we start an open procedure, because we need to map to know where you're going to do the bypass to. And if you're doing an angiogram, what's the harm in trying to open up the vessel, is my point. So is Dr. Yasa on?
Yeah, Anita, hi. How
there you
doing?
are. Hi,
Great,
how are you?
great to see you. Well, as you know, I'm a vascular surgeon, but I moved to the dark side, to the endo side, several years ago, still performing distal bypasses. So the thing is, I think we all agree, and I cannot agree more with John or Jihad or Lorenzo, that nothing is better than a fit guy with great vein. But the thing is, this is quite unusual to find in our clinics. They are not fit enough for a complex open surgical procedure. And as Lorenzo has mentioned, 44% of them don't have a proper vein. So I would say that definitely we need to adjust our indications to the sort of patients we deal with. My main criticism to the trial is it is the best CLI trial, but as you mentioned, at the best endo procedures with the best endo physicians, I definitely doubt it. Nobody of all of the panelists in this nice session today would agree that 50% failure rate is something that we can assume. Anything over 5%, it's a disaster from my side. So with regards to your question, we perform an angiogram beforehand, or we perform an angio-CT, and then we decide with all of the conditions of the patient and which is the best strategy for us.
Excellent. Thank you very much. And that's very similar to how I practice as well. Pretty much because of the tibial disease and being difficult sometimes when you have multiple levels of blockages, because the way a CT scan works is you shoot some dye into a person's body, and then it's supposed to travel from the heart all the way through to the toes, and the CT scan sort of follows and takes a look at each section. But if you have multiple blockages, it messes up how quickly the dye gets to the toes, and sometimes the dye doesn't make it at all because the vessel is so tiny and there's too many blockages. So an angiogram is excellent to really see the flow. And so at least for me, I've moved to pure angiograms to determine if patients are bypass candidates, and will always attempt an endovascular option in these patients, even if it's just a mild attempt. You know, if my wire is just not going, of course, I don't want to mess up a bypass target, so I don't want to get into trouble. But at the same time, if I can get them blood flow today on the table, to Dr. Runback's point, then you know they have to get a stress test, then they have to get booked, then we have to harvest vein. There's a lot before I can get them their bypass versus just getting them some blood flow on that day to keep their wound stable. So I'll turn it over now to Mr. Valls. Can you talk a little bit about the trial design itself, what you thought were the strengths, what you thought were the weaknesses, given your exposure to trial design for PAD?
Hi, Anahita. Thank you very much for your introduction. Let me say that I love when you're talking about patient. You're saying the word patient. And it's because we are changing the paradigm. We are changing the model in which we used to work in the healthcare. We are changing from a volume-based healthcare system to a value-based healthcare system with a patient-centered model in which we will be based on value, and the value will be based on results. relevant results for patient in order to empower the patient in the end and give them the most important information and relevant information in order to participate in the final decision making, because in the end, if they have the full information, they will be part of the decision making. And according to that, we are trying to generate an algorithm. And I agree with this best CLI study that we need to generate the best algorithm possible to treat CLI patients based on clinical results, economical results. And this is something that I will disagree with this clinical study, that is based on real world evidence patients and then on patients' preferences. Talking about limitations of this study that I was reading and analyzing is that the operator experience, it will be not the same. You were talking about different kind of specialities of doctors without many times a clear specialization in CLI treatment. Then there is a bias in the study about operation selection of material. The information that the operator has in each kind of material is not complete information. It's not well backpacked with a large real world database in order to have full information and to select correctly or properly the device that we used to use in the endovascular field. Then there are patient environment preferences that we are not taking into consideration. And also, I agree with you, what happens after the procedure. So there is first patient responsibility. We do not talk about which is the responsibility of patient in terms of diet, smoking, drinking, walking after the procedure, but also the post-procedure medical treatment, as you were talking about. This is a randomized clinical trial. I would prefer, and I'm member of the International Health Economics Association, ISPOR, and the trend for us is to start working every time more and more with real-world evidence databases. And this is the future that we are putting on the table, having that kind of large databases without any kind of filter, and use artificial intelligence in order to identify the correct algorithm of treatment for each patient, for each treatment, but also for each patient environment in terms of family environment, working environment, and all that. So this is more or less the critics or the comments that I have to say about this study. Thank you.
Thank you. That's very thorough and excellent. And I agree 1,000% on everything you said. We are about 15 minutes before we end. So I have 3 more questions that are actually from patients that have been submitted that I want to discuss. So Dr. Mustapha, if you're there, I'd love to ask you, this is from our patient, Rebecca. She described an experience basically where she walked and walked and walked, and ultimately now she's left with what sounds like neuropathy, which potentially could have been prevented had she had an intervention earlier if she had flow down to the feet. Now, it's hard to say because, of course, I'll put out by saying a lot of our patients have diabetes and the neuropathy comes and there's nothing much that you can do, and certainly getting blood flow wouldn't have changed that. But also there is something to be said about ischemic nerves. So how do you decide, Dr. Mustapha, when you are going to intervene on a patient and how aggressive you're going to be? Are you going to go into those tibials? Are you going to come from the foot? How do you make that call?
Thank you, Anita. And I want to thank the patient for asking that question, because it's really an important question that we face on a daily basis. So neuropathy has been debated back and forth, but is there such thing as ischemic neuropathy? Basically, you have a prolonged ischemia that leads to nerve damage. That's been discussed and it's not been agreed on, so it's out there. In terms of when do you treat, based on a recent publication by the American Diabetes Association, they stated that some of the delay in therapy have led to some almost 85% of amputations that could have been prevented. So that's the other spectrum of the deal here. So let's go in the middle. When someone have symptoms that progressively getting worse, are not improving with medical therapy, walking programs, everything that you can do for them, it is time to actually take a look and see, because early intervention tend to show a better outcome in the long terms, and that has been published in many journals and many KOLs. I would say that in your setting here, before you got neuropathy, maybe if you got therapy, probably you would not have got the neuropathy, but I don't know 100% because the data is still 50-50. Some believe in it, some don't believe in it. My concern is for you, if you continue to stay without therapy, would you get to the point where you have rest pain, you can't sleep at night, or you get a wound at one point? And then if you do, then the process changed completely. You go from just having pain, and now you have an ulcer, and the ulcer is going to progress to something else, and then amputation. So early therapy, in my opinion, is an important thing. And that is because of the data that's out there that indicates early therapy is better than delayed therapy after performing the walk-in program, America therapy, and all the things they need to do first. And I want to take a just quick moment to say that, that was published in the AHA recently, saying that the mortality rate and the amputation rate is going up by 1 to 2% per year. That's for all of us, right? Over the last 4 years, year after year, 1 to 2%. So with everything we're doing, why is that still going up? So I want to take a moment here to say that despite everything we're doing, the amputation rate is still going up 1 to 2% per year. So maybe we can all call for an action here to say that we need to be hopefully not aggressive to the point that we just treat everybody, but treat somebody like our patient here who is actually progressively getting worse. For anyone that progressively getting worse and not improving with therapy, probably should get therapy early sooner than later.
I couldn't agree more. Absolutely. And I think, that's important. There's a lot of data that came out 10 years ago, 15 years ago on certain patient populations. And, Mr. Val used the statement, real world. And that's the key, right? We exclude so many patients from these trials because we want to look at one tiny little thing. And a lot of times it's the majority of the patients that we actually see. So there are two major calls to action. One is we need to work with the multidisciplinary segment. We've got to stop the infighting and really ensure that we're taking care of patients. And the other big thing is that we need to get the data to support what we are saying, what we all know from our anecdotal evidence. But that only works if we come together and we can do that again for our patients. So something that hopefully Mr. Val can help us design trials for. May I ask Dr. Petrone, if you're there, I'd like to ask you a question that came from another patient, Douglas. The long and short of it is that this was a very expensive trial. We have this data now. There's all these subgroup analyses that are coming out. At the end of the day, is this trial changing your practice?
He hasn't answered, actually. I've sent 2 patients so far to my friend, Dr. Neville, in your neighborhood for tibial, actually one for pedal bypass and one for tibial bypass. But they met all the criteria. So it did make a difference for these patients. And these patients were sent to me from somewhere else. We could have revascularized them, but they met all the criteria. And actually both are doing really well. So there's a good benefit that came out of the study. And we should take advantage of that because we could probably establish quality metrics out of it someday together. There's a lot of good things. There's some things that are still in question and some things in between. So
yeah, I completely agree. In the last 5 minutes, I'm going to ask a very loaded question, not from me, but from our patient, Frank. So here's I want the whole panel.
Sorry, can you hear me?
Oh, no, we couldn't hear you. We couldn't hear you at all.
Okay, I'm so sorry. No, I'm just saying very quickly. Very quickly. That's something that never came out from this call. It's like we were judging now technical data. So how the bypass performs versus endo, how the prosthetic bypass performs versus endo. But if we go to the
we can't hear you.
Yeah, can you hear me?
Now we can hear you.
Can you hear me now?
Yes.
Okay, so what I wanted to try to transmit is that when you go to quality of life, for me, it's the best outcome you can the best target we should keep in our mind. At the endovascular versus even a venous bypass performs the same. So if you look at the answers that the patient give after the treatment, are you happy? Are you happier than before after the treatment? Actually, the two things go together. So essentially, there's no benefits, despite the technical result be better for the vein bypass in the group of patients that they choose. Still, the quality of life improvement, this is something that I really care for my patients. Not about is the bypass patent or concluded, but is the patient better or worse? Is the same between endo and bypass. So essentially, this is a strong
evidence that, of course, endo works very well, especially in good hands, and should be really offered to all the people who are willing to go for this.
Absolutely agree with you, Dr. Patrone. So if we are considering quality of life for patients, I think that we need to link that argument to a cost-benefit analysis after clinical studies in order to analyze and to ponderate the weight of the cost of each treatment versus the benefit for the patient. And this is absolutely the trend that we are facing right now as health economists in the market.
Right. And we have to be able to determine, how to do that correctly. Because even right now, you could argue, if you look at just hospital stay, you do an amputation on somebody and you send them out the door, that's going to be less expensive in that if you just look at the hospital stay than doing a big endovascular procedure or a bypass that might put them in the ICU for a little bit. But if you look overall at the patient over life, indeed, if they save their leg, they work in the economy and they do all kinds of positive things that will be cheaper.
The first case that you were talking about is, for example, Dr. Mustapha performed many time ago a trial called Calcium 360 with orbital atherectomy system. From there, they did, after an economical analysis that they were saying that was a cost effectiveness analysis, but at the end was a budget impact analysis. Exactly what you were saying, which are the costs pre the intervention, during the intervention, and after the intervention for the center, for the hospital, and comparing both arms. This is a budget impact analysis or cost effectiveness, it's true. But what we need to look for is cost benefit for the patient. When you are linking the cost for the insurance company in the United States or the public healthcare system in Europe with the benefit for the patient. Benefit for the patient is based on quality adjusted lives of year. And this is the kind of analysis that we should start doing after the clinical studies. And I think Dr. Mustapha has large experience on that.
Yeah, I agree with you. Actually, in fact, we did the Liberty 360 to follow up on that. And I totally agree. The economical aspect showed more in the Liberty 360 than the Calcium 360, if I heard you correctly. But thank you for that info.
It's true. In Liberty 360 that you are doing a follow-up up to 3 years, I think, the last results.
We have 3 years now, but we're going to follow for 5.
Yeah, fantastic. So it's written the increase in quality adjusted lives per patient and also for category. So it's an incredible good analysis for that kind of patients. So congratulations for this study, Dr. Mustapha.
Thank you.
So Anahita, answering your question about if best CLI is going to change our practice, I've been following a lot of webinars, events, conferences talking about best CLI, and I would say that nobody is massively going to change their practice. There's a bunch of good New Year resolutions, like we should scan great saphenous veins, we should optimize the control of risk factors, improve preoperative assessment, train endophysicians adequately, or emphasizing the multidisciplinary approach. Will this happen? Who knows?
Right. And that's part of the difficulty of being in this space, right? We know what is best. We are achieving it for our patients. The numbers of patients with diabetes is increasing significantly across the globe. So there are going to be patients in every kind of second that we walk. And so there's no problem with the number of patients. The problem is with the multidisciplinary approach and having everything you need in each center. And so with that, I will say, for our patients that are on this call as the final word, everyone that you've heard speak, care about you and care about your outcomes. And that's really the most important thing that I can impart to you. You as patients will never be able to do all the nuances and all the checks. And, you're going to talk to your friends, you're going to talk to other doctors, you're going to come on these panels, and you're going to sometimes get overwhelmed and confused as to what you need to do. And there's only one thing you need to do, and I task you with, and that is find yourself a compassionate vascular interventionist. You find somebody who gives a crap. That person will go to the ends of the earth to make sure that you're taken care of.
And we love you.
Be in every way that you need to be. And it doesn't matter if they're IC, IR, vascular, even your primary care doctor will find the person that will take care of you. So you take the step to make sure you do that. And you can tell in an interaction who's looking at you in the eye, who's there to answer your question, who's not getting irritated, et cetera, et cetera. You find that human being, and then that's your person, because as what's already been said on this repeatedly is this is not a one-time show. You're not coming in and getting a fix and walking out. This is a marriage you're going to have with this human being for the rest of your life, most likely, because vascular disease is going to be all over your body. And so it's important that you find that human being, and we exist. We're all over the place. You just have to take that extra step. Okay.
What are some of those criteria, though, that they can use to determine, because they can like and they can trust and they can have the kindest doctor in the whole world that doesn't know what he or she doesn't know. So as a patient, how do they go in and find this particular doctor that's not only kind and compassionate and gives a crap about them, but also has this skill set to be on the journey for the long term with them?
I think the most important thing is to do your research about the actual person. I'm not saying that they need to publish books and write a bunch of papers. In fact, sometimes those people don't actually do the work. Those are just people that are giving the talk.
Hey, Anita, be careful here.
I know. But I mean, both me and Dr. Mustapha publish extensively and work. But that's what I mean. We're unique, though. I mean, we're here, right? We're here on a Saturday having this conversation with you. And so those are the sorts of things that indicate that this is a person that really is involved and deeply entrenched in this and knows what the most cutting edge way to manage things is, and connected. I need to be able to send you to a great podiatrist if you need a podiatrist, or a great vascular medicine doctor, or et cetera, et cetera. And, Dr. Mustapha, for example, been entrenched in this community for years and years. Hundreds of thousands of patients can vouch for him, and that's how you have to do your research. And you can ask us. This is what this network is for. Kim exists for you, that she can do some of that legwork for you to kind of help tease out who those people are.
I want to say that one quick thing from Dr. Yesa from Europe. I mean, we actually following some of your work. Thank you for putting your program together. And everyone here, Alba, is the same thing, and I can say the same thing on every physician on this panel. I learned from you. Actually, we steal some of your work. Steal is not the right word. Maybe borrow it so other patients can benefit from it. And this is what community is all about. And hopefully we continue to do that together. Great. And Kim, thank you for everything and putting this group together. You deserve the biggest. Thank you.
Oh, thank you. Well, I couldn't do it without all of you. I appreciate it so much. And you guys can tell me if I'm wrong, but some of the things that when I talk to a patient about choosing a doctor, we talk about not only endovascular skills, but we talk about surgical skills or affiliations with a proper doctor who can perform a bypass, an endarterectomy, or even some hybrid approaches to treating these blocked arteries. When it comes to endo, we always suggest to patients, make sure that they can offer multiple approaches. What if they can't get through a blockage coming down from the groin? Do they have the skills to be able to come up from below? We call it a retrograde approach. Can they poke into the foot? Can they poke into the calf and come up and try from below? Do they use intravascular ultrasound to, in a sense, dot their I's, cross their T's? It's known as IVUS. It's an additional imaging tool that helps these doctors to size and place balloons and stents. I know that Dr. Runback, I believe, was talking earlier about the importance of that as well, or one of the doctors was. When it comes to bypass and endarterectomy, though, and some of the surgical procedures, I'm wondering from Dr. Dua's perspective, what are some of those advanced skills or questions that a patient can ask to ensure that doctor is not still cutting from groin to toe for a simple fem-pop bypass?
Well, before I answer that, I'll just say, just so you guys know, when you have a vein bypass, okay, that requires that you are going to have 2 independent incisions, usually. You're going to have one incision that's going to be kind of from your ankle to your groin, either on the opposite leg or your same leg, from where we harvest your vein. But that incision is about 0.5 centimeter deep. But it is the one that is really long and jarring to patients. But that's where we have to take a nice long piece of your vein, because remember, when we tunnel it through your leg, we lose inches where it twists and turns. And so we need to take the entire length of it, and as much length as possible. And as they say in surgery, we think twice and cut once, because once you've made that cut, you can't sew it back together. And then the other incisions that you will see on your leg are where we have the top connection and the bottom connection on your arteries. And that may be one usually in your groin, and then one somewhere on your calf, on the inner or outer aspect of the calf. And occasionally we can use the same segment of your vein harvest site to kind of dive deep and make the connection. And the easiest way to figure out whether or not the doctor does those sorts of things is to literally ask them. You just say, what's your specialty area? Are you somebody who does a lot of bypasses? Indeed, bypasses are kind of a common piece of being a vascular surgeon. So anybody who is a vascular surgeon will have the basic skill set to be able to do something like that. And if it's more advanced, there are people that do tibial bypasses, and partners will very often shuffle patients back and forth to try to get you the best outcome possible. So that's something to know, that don't be worried if the incision is very long, but ask your doctor so that expectations are managed prior to the procedure.
And you didn't even mention, for the most advanced patients who don't have surgical, even endovascular options, the emergence of really novel therapies such as deep venous arterialization, which, while still being explored, is not done by everybody. But I posted earlier, the main message is don't get amputated, because the results after amputation, both in terms of overall well-being, ability to ambulate, and survival, are poor. And you really should, at that point, really try to find people, and you utilize Kim for this, who can perform some of these very sophisticated and advanced therapies, either normally or in a clinical trial.
Fantastic. Any final thoughts? I wanted to give each person on this highly esteemed panel a chance to give your final takeaways. Critical questions patients should ask their doctor based on this discussion, what they should take away from this discussion. I'll let each of you, we'll start with Dr. Rundback since you are already up.
Yeah, look, this is absolutely fabulous. We've only been able to touch the surface. I keep on repeating the message: don't get amputated. If you see a doctor and they tell you that is your only option, you should realize that very often it is not your only option. And that's when you need to use your resources to find doctors who really care and might be able to do other things and explore all possible other options.
Dr. Dua?
I echo that sentiment, and I think when you hear amputation as the final end, you should ask why. With my patients, amputation is a therapy that occurs occasionally when things are too far gone, because of only two reasons. One, they are getting actively sick from the leg, as in you're going to die if you don't have this dealt with, or if you're in such extreme pain that you just can't take it anymore and you're going to, cut your own leg off if the doctor doesn't do it for you. And this is, of course, after attempting, to salvage the leg. And so I think, when the doctor says that, you should say, can you tell me why other options are not possible? Like, as Dr. Rundback just said, deep venous arterialization, why am I not a candidate? And, we don't do that here is not an answer. So that's what I would urge you to do if you get faced with that, because one of the things that does happen, and you should know this as patients, is indeed, you get labeled even as patients. And if you're doctor shopping and walking around and not liking what you're hearing, you have to be careful about, where you live in a particular area being labeled as, it's just that patient who always comes in with some weird Google piece of paper and tries to determine what his or her own care needs to be. There has to be some trust with the doctor, and you do have to listen. So it is a back and forth. On the other hand, it's not paternalistic where you just do everything the doctor says without questioning. So I urge you to kind of find that respectful space where you respect your doctor enough to understand what they're saying to you and force them to give you all the information, and just be careful about how much of your own research you do without a lot of the understanding of the medicine behind it.
And Dr. Yusuf?
Well, I would say you don't actually need to have the perfect physician, the perfect endo, the perfect vascular surgeon. You need to have a good one who performs whatever, but performs it well. I love the term brought by jihadmustapha, the CLI fighter. And as Anahita has mentioned, look for your CLI fighter to trust on him, and don't accept a major amputation, as Jihad also mentioned, without having an angio, because this is definitely unacceptable.
Right. Still 90% of amputations are occurring, surprisingly, without even an angiography in the year prior, is the last study I saw. So it's still concerning. And Dr. Petrone, are you still on with us?
Yes, I am. I think I have a very short sentence, but very important. Get treated early. As Dr. Mustapha said before, there's an incredible difference in being treated when there's what is called rest pain, so pain because of the lack of blood flow, and when you develop tissue loss. So the outcomes of these patients are completely different. So when you have pain in your foot, go get tested and try to understand if that pain is caused by the lack of blood flow to your foot. That's the best thing you can do. Then go to any doctor, but go at least to a doctor, because sometimes time is the issue.
Yep. And Albert, do you have any final thoughts?
Well, as Adam Smith used to say, an optimized decision is based on complete information. So you need information, second opinions, patient advocacy, as you are doing, Kim, is the key. And then to start, if we are talking about mid and long-term objectives, is to control that patient database by patient advocacy groups like yours in order to analyze independently the results.
Thank you. And last but not least, Dr. Mustapha. Okay, well, I'll turn it back over to Dr. Dua for the wrap-up.
I want to thank you all very much for taking the time to come. Kim, of course, you're amazing. Dean, amazing. Thank you for doing this. And for our esteemed panel, taking the time out of your Saturday to do this. And thank you to your families as well for allowing you to do that. Whatever Dr. Petrone has given his children, I need that shipped right away for my children. I could never, I'm just looking at you in absolute shock and awe. Amazing. But well-behaved children. But I want to tell you all as patients that don't worry. I know it's a lot of information again, but we are all out here and we're ready to help you. And this is a network that I think you really should explore and use. If you ever get into a situation where you're worried and you need some help and you just, you're not getting the answers you need, we're all just a phone call away. So that's what I'll leave you with. We don't expect you to know everything about something that took us decades to learn, but do know that we do know it, and we are here to advocate for you and take care of you.
Thank you so much, Dr. Dua. You were amazing, and I appreciate every single one of you for joining us.